Hello.
Hello. Good evening, ma'am.
Yeah, good evening, Miss Varsha. Yeah, good evening. Bhale sir, good evening. Hello. Oops. Bhale sir, good evening. Manik sir, akka honey.
गुड इव्हनिंग सुजाता. आवाज सुजाता.
गुड इव्हनिंग सर. आवाज येतो आता?
हा आता आला आवाज. येस.
ओके ओके ओके. माणिक सर जॉईन. माणिक सर दिसतात होते.
अच्छा.
आय डोंट नो.
येस येस हो झाले.
हो. गुड इव्हनिंग दीपक. संगीता मॅडम गुड इव्हनिंग.
हॅलो हॅलो.
हा गुड इव्हनिंग संगीता मॅडम. मीटिंग आहे.
हॅलो हॅलो.
Hello. Good evening, Sangeeta ma'am.
हा गुड इव्हनिंग वर्षा.
Yes, ma'am. You are audible.
येस येस. मला अनम्यूट करू नकोस.
Okay, okay.
हा. सुजाता तू पण आलीस ना?
Yes, ma'am. Sujata ma'am पण आहेत.
ओके ओके. म्हणजे मी काय करते, मी आता वेलकम करते आणि इंट्रोडक्शन करते दोन्ही चेअरपर्सनची आणि मी नंतर चालू ठेवून मीटिंग घरी पोचते. म्हणजे आपली सुरुवात होऊन जाईल. ओके.
Okay, okay, ma'am.
हा मी तिथेच जिथे कॉलला गेली होती तिथेच कन्सल्टिंग मध्ये बसली आहे.
Okay, okay, ma'am.
हा सुजित आला का?
संगीता मॅडम.
हा बोल.
सुजित सर येत आहे.
हा ओके.
एक 5-10 मिनिटं आपण वाट बघूया.
नाही आपल्या वेळ आहे अजून 8 मिनिटं आहे सुजाता.
राईट.
पण मी काय डिसिजन घेतला का मी घाई गडबडीत जाणार त्याच्यापेक्षा मी शांतपणे वेलकम करते. राईट. हॅलो
हॅलो. संगीता ऐकू येते का?
हा तुमचं ऐकू येतो. सुजाता काय बोलते?
हा मॅडम आता येतं ऐकू.
आता येतोय.
येस. तर आपण सुरू करू. मी म्हणजे वेलकम हे करते. देन आय हँड ओव्हर यू अँड सर आले की आपण सुरू करू. देन यू कॅन.
आम्ही जॉईन झालेला आहे.
गुड इव्हनिंग सर. गुड इव्हनिंग.
गुड इव्हनिंग.
हाऊ आर यू?
अमित, नाईस टू सी यू.
येस थँक्यू सर. गुड इव्हनिंग संगीता मॅडम. गुड इव्हनिंग.
गुड इव्हनिंग अमित सर. गुड इव्हनिंग.
हाऊ आर यू अमित?
ऑल वेल थँक्यू सो मच. थँक्यू.
दीक्षित सर नमस्कार.
अरे बापरे. थँक्यू.
अमित आता औरंगाबादला यायचंय तुला.
हो सर बिलकुल.
नॅशनल
दिवस
सीएमई
झाले.
आपण करू, छान एन्जॉय
करू सर, डेफिनेटली.
We will wait for some few minutes, then we can start.
डॉक्टर अमित, आपण आला होता, मला वाटतं आम्ही रिजनल वरती केली होती 2017 मध्ये, तेव्हा आला होता ना आपण?
हो, आलेलो आहे मी अगदी म्हणजे यांचा बऱ्याच महाराष्ट्र मिझॅकॉनलाही आलो होतो, मागे पण आलो होतो. आणि एकदा तर मला वाटतं त्या झाडे यांच्याबरोबर, सुजित सरांबरोबर आम्ही एक असंच इम्प्रॉम्प्टो सेशन पण घेतलं होतं सुरुवातीला. मला वाटतं ते इकडे होतं तेव्हा.
सिग्मा मध्ये आपण केलं
सिग्मा,
होतं. डिफिकल्ट एअर वर तू घेतलं होतंस आमचं.
हो, बरेच दिवस झाले.
आणि MGM ला पण आले होते.
MGM लाही एकदा झालं होतं.
लाईव्ह होतं तेव्हा, आपलं लाईव्ह डेमॉन्स्ट्रेशन्स वगैरे होते.
एक करूया आता आपण. आता खूप सारं मटेरियल पण आहे आणि भरपूर लोकांना इंटरेस्ट पण आहे. आणि आपली सिस्टीमही छान डेव्हलप झाली आहे सगळी. MGM ला तर काही प्रश्नच नाही. बाकी सगळ्या ठिकाणी छानच आहे.
आता कोरोनामुळे सगळ्यांनी हे अडॅप्टच केलेलं आहे. आपण एक 5-6 मिनिटात चालू करूयात सर. डॉट चालू करूयात. तुमच्या एवढ्या बिझी शेड्यूल मधनं आम्हाला तुम्ही वेळ दिला, थँक्यू सर.
नाही, तसं काही नाही मॅडम. इट्स ऑलवेज, मला खूप आनंद होतो. आणि आम्ही आता मध्ये बरेच फोकस वर्कशॉप घेतले, मास्टर क्लास घेतले, आणि इतकं मजा येते पोरांना आणि सगळ्यांना शिकायला आणि नंतर ते फॉलो करायला. त्याच्याने ऍनेस्थेसिया भरपूर इंटरेस्टिंग वाटायला लागतो. लोक अगदी सगळेच जण खूप इंटरेस्ट घेतात.
अनुष्का, पप्पाला फोन लाव.
तर पुण्यात कसं आहे कोरोना आता?
आता बरंच कंट्रोलमध्ये आहे मॅडम. मागच्या आठवड्यापर्यंत थोडीशी लिस्ट, जरा एखादा पॉझिटिव्ह निघाला म्हणून कॅन्सल वगैरे असं थोडंसं मागचे 2 आठवडे झालं. पण आता थोडंसं मला वाटतं ऑलमोस्ट क्लिअर होत आहे. रेग्युलर आलेली आहे आता जवळजवळ. म्हणजे सगळ्यांना होऊन गेला असंच म्हणावं लागेल. बरेचसे आमचे सर्जन, ऍनेस्थेटिस्ट, पीजीज सगळे एक राऊंड कम्प्लीट झालेला आहे. त्यामुळे आता लोक म्हणे,
पहिल्या 2 लाटेत मी वाचली होती, तिसऱ्या लाटेत आले, थर्ड वेव्ह घेऊन गेला.
थर्ड वेव्ह खूपच इन्फेक्टिव्ह होती, त्यामुळे काही.
एक्झॅक्टली. आणि काय होतंय, पोस्टअप सुद्धा पेशंट बरेच पॉझिटिव्ह निघतात आहेत नंतर, त्याच्यात ते देऊन जातात आपल्याला.
हो, ते मग थोडस आठवडा 10 दिवसांनी सर्जरी, तेही थोडा बॅकलॉग झालेल्याही सर्जरीज आता जरा जोरात चालू आहेत. त्यामुळे सगळेच चालेल.
सुजितला रिलीव्ह केलं का ग कोणी?
हो, आले सर, आले. 1-2 मिनिटं फ्रेश होण्यात.
भाले सरांचे बरेच अकॅडमिक पोस्ट आम्ही बघतो, उत्साह वाढतो एकदम. रिजनल फार डायनॅमिक पद्धतीने चालू आहे. छान एकदमच मस्त.
आम्ही सुरुवात तुमच्यापासून झाली. तुम्ही एवढा रिजनल मध्ये इंटरेस्ट डेव्हलप केला आमचा की वी आर डुईंग दॅट.
यावेळेस 8-9 एप्रिलला आहे सर प्रॅक.
ओके,
एप्रिल 8-9 अजून थोडं करतील सर. फ्लायर वगैरे येईल. एओआरए पण आहेच. आणि गार्क मे मध्ये आहे, 5 ते 8 मे. बरं. आणि एओआरए सप्टेंबरला आहे, 29-30, 1 ऑक्टोबर. मुंबईलाच आहे यावेळेस.
ओके, मुंबईला.
थोडस परत पूर्वीसारखं आता आहे, म्हणजे एखाद दुसरी कुठली तरी करू शकतो आरामात, म्हणजे प्लॅन करून निश्चित भेटू आपण. हो, करायचं म्हणजे तुमच्या भेटीसाठीच करायचं आम्ही. अरे बापरे. सगळ्यांच्या भेटी होतात. हो, नाही छान सर. ते काय थोडस आम्ही सगळं इंटरॅक्शन मधूनच शिकतो, हे वेगवेगळ्या युक्त्या, आणि वी ग्रो विथ ऑल द एक्सपिरियन्स, खूप साऱ्या इंटरॅक्शन. सुजाता, अमितचा खूप मोठा सपोर्ट आहे. ऍट एनी टाइम ही इज अवेलेबल 24/7.
येस, डेफिनेटली. एकदम एन्थुसियास्टिकली लगेच म्हणतात, म्हणजे
कधीही काही लागलं तर
कधीही. हो, खरंच आहे.
He will guide us and
हा.
definitely guiding us.
मध्ये मी भारतीला घेतला, एक मास्टर क्लास होता याचाच फोकसचा. तर ते म्हणाले की सर म्हणे आता आम्हाला थिसिस टॉपिक फोकसवर देता येत नाही, कारण म्हणे इतके आधीचे झालेले आहेत की म्हणे तो अल्ट्रासाऊंड इतका बिझी असतो की म्हणे कम्प्लीट होईल की नाही थिसिस अशी काळजी आहे. एवढं ओव्हरवर्क झालेलं आहे. सो कोणाचे डायफ्राम वर चालू आहे, IVC, गॅस्ट्रिक अल्ट्रासाऊंड, सगळे वेगवेगळे ऍस्पेक्ट्स आता ऑप्टिक नर्व्ह शीट डायमीटर, म्हणजे एवढं जोरात आहे.
अवेअरनेस वाढलाय आणि फार युजफुल आहे ते.
फार
पटापट
फार
इमिजिएट.
ICU मध्ये वगैरे पण गॅस्ट्रिक कंटेंट आणि बऱ्याचशा छोट्या छोट्या गोष्टींसाठी वगैरे चांगलं हँड्स ऑन होतं, आणि एक मशीन ICU मध्येच असल्यामुळे बऱ्यापैकी त्यांना एक्सपोजर.
सिलेबस मध्ये सुद्धा ऍड करायचं चाललंय.
हो, सिलेबस
We will
मध्ये.
add it in syllabus. MD anesthesiaच्या सिलेबस मध्ये आता चेंज करायचं मला. I will add this.
बिलकुल
Focus.
बिलकुल बिलकुल. रिजनल मध्ये आम्ही बरीच ओरडाआरड केली, तर आता रिजनलच्या प्रत्येक कॉन्फरन्सला आय एम शुअर इथून पुढे एक फोकस वर्कशॉप डेफिनेटली असेल.
Yes, yes.
कुठली नॅशनल इंटरनॅशनल असो, इज नाव कॉमन फीचर. त्या युट्यूब लिंक वरून लाईव्ह आहे का बाकीचं, असं मला वाटतं तिकडे.
हो, युट्यूब वरती लाईव्ह असतो
आहे,
सर.
आहे.
युट्यूब वरती लाईव्ह आहे आणि रेकॉर्डिंग पण मिळेल आपल्याला.
अच्छा अच्छा.
हा.
मी एकदा प्रेझेंटेशन थोडं हे करून बघू.
हो, प्ले करून बघता का सर? स्लाइड्स दिसतात की नाही?
हा, असं थोडस.
ओके ओके ओके, करून बघा सर.
दिसतंय का ही स्लाइड?
हो, व्यवस्थित व्यवस्थित दिसतंय.
ओके, थँक्यू.
फक्त प्ले होते का एकदा बघा, एक दोन पुढे मागे करू. बऱ्याच वेळेला ते प्ले हे होत नाही, पुढे मागे स्लाइड्स.
हा, दोन्ही करून बघ. हा,
होतंय ना?
येस.
होतंय.
ओके.
ठीक आहे.
या.
Thank
ओके.
टेस्टिंग इज परफेक्ट. या.
Yeah. Sujit sir has joined.
Hi, Amit.
गुड इव्हनिंग सर. गुड इव्हनिंग.
Amit.
येस, गुड इव्हनिंग.
वेलकम सुजित.
Thank you, madam.
I think Naik madam is there.
Madam, namaskar.
Madam, good evening.
गुड इव्हनिंग नाईक मॅडम.
गुड इव्हनिंग मॅडम.
हॅलो, नमस्ते.
गुड इव्हनिंग.
मी म्यूट करते आता.
छान वाटलं मॅडम तुम्हाला बघून खूप दिवसांनी.
भोपे सर आहेत. गुड इव्हनिंग भोपे सर.
ओके सर.
गुड इव्हनिंग.
गुड इव्हनिंग. गुड इव्हनिंग सर.
सर, गुड इव्हनिंग. थँक्यू सर फॉर जॉईनिंग.
प्लेजर.
मॅडम थांबायचंय का चालू करायचं आपण?
आपलं हे फोरम झालं असेल तर आपण चालू करूया आता, कारण 7:05 होत आले. स्टार्ट नाउ. या.
अमित सर आली द्या. Very good evening. Am I audible?
या.
Okay. Oh, very good evening to all, respected seniors and dear colleagues. Myself, Dr. Sujata Jine, welcomes you all for today's academic feast for the month of February from Team Association of Anesthesiologists, Aurangabad. Last month, many of the office bearers and their family members were down with COVID-19 infection. So we had a lag in academic event. But I'm sure today's meet will be a double dhamaka by a very enthusiastic and a dynamic faculty of today's session, Dr. Amit Dikshit. Also, we have a phenomenal chairpersons to interact and make the sessions very active. Now I request our president, Dr. Sangeeta Deshpande Madam, to please extend warm welcome.
I, Dr. Sangeeta Deshpande, President of Association of Aurangabad, welcome our Chief Speaker, Dr. Amit Dikshit sir, all dignitaries of MSCISA, my chairperson, Dr. Sujit Khade, and Dr. Bhale sir, and all my friends. I welcome Dr. Amit Dikshit sir with a floral bouquet.
Thank you very much, madam. Thank you.
I also welcome our chairperson, Dr. Pramod Bhale sir, and Dr. Sujit Khade with floral bouquet. Varsha, please bouquet display kar, share kar. Hello, Varsha.
Yes, ma'am. Yes.
Yeah. सुजित आणि प्रमोद सर बुके मिळाला आणि
Thank
Thank
you
you,
very
madam.
much.
Thank you.
Thank you, madam. Thank
Thank
you.
you. Thank you so much.
I'll introduce first Dr. Bhale sir. Dr. Pramod Bhale sir, at present designation, he is the professor of anesthesiology at Mahatma Gandhi Medical College, Aurangabad. He is a GC member at MSCISA from Aurangabad branch. He has done fellowship in chronic pain management, second fellowship in USG guided chronic pain interventions. He has his 15 original research publication. He is peer reviewer at Indian Journal of Clinical Anesthesia. He was also vice president at ISA City Branch Aurangabad during the tenure of 2014 to 2016 and had conducted ANACON in 2015. Now I introduce Dr. Sujit Khade. He is very efficient, multifaceted, dynamic young personality. At present, he is consultant cardiac neuroanesthesiologist and he is director at Ozone Anesthesia and Critical Care Private Limited. At present, he is affiliated with United Sigma Hospital and Seth Nandalal Dhuth Hospital. His major achievements: active participation in first heart-lung transplant and in Marathwada region. Honorars awards: President Appreciation Award at 21st Annual State Conference, Solapur. Publication: prizes received at ISNAAC 2006, WAD Conference 2010, MISACON 2016 and MISACON 2018. Dr. Sujit was Secretary ISA City Branch Aurangabad during tenure of 2014 to 2016. He mastered skill of cervical epidural and he has done more than 250 cases. He is expert in putting subclavian central line. Next, he was also organizing secretary for ANACON 2015 at Tapadia Natya Mandir, Aurangabad. His non-academic interest is reading, cycling, and business development. He has also delivered lecture at WealthCon, Aurangabad. Welcome, Dr. Sujit, and welcome, Dr. Bhale, sir. Shall we start?
Thank you, madam.
Yes. So shall we start with the lecture on Dr. Amit?
Madam,
Madam, I will introduce.
introduction Bhale sir दे रहे थे.
Yes. I am ready. Am I audible?
Yes,
Yes,
sir.
yes, sir.
Good evening, everyone. First, I would like to thank Association of Anesthesiologists Aurangabad for giving me opportunity to chair the session. It is a great honor and gives me an immense pleasure to introduce esteemed faculty Dr. Amit Dixit. At present, he is working as a consultant anesthesiologist, Ruby Hall Clinic, Pune. Course led by him are Regional Anesthesia, MUHS Fellowship, and Regional Anesthesia AORA Fellowship. He is member of Board of Studies and Fellowship AORA India, peer reviewer Indian Journal of Anesthesia, member of PICEU Foundation, and he is course director for structured regional anesthesia workshop under PICEU Foundation in association with usabcd.org. He is also course director, course coordinator for several workshops on basic and advanced echocardiography. He contributed chapters in regional anesthesia and POCUS handbook by Springer Publications. He also contributed videos in POCUS Today app, an initiative by National University Hospital, Singapore. Our today's topic is anesthesia excellence with perioperative POCUS. POCUS refers to use of ultrasonography at patient's bedside for therapeutic, procedural, and diagnostic purposes with real-time images. It improves safety of many of the interventions used in anesthesia care. I request Amit Dixit to guide on anesthesia excellence with perioperative POCUS. Over to Dr. Dixit.
Yes. Thank you very much, sir, Bhale sir, for those kind words. It is always, very homely feeling when we have it is back to Aurangabad and areas of. So just give me a minute. There was a little. Give me a minute, please. Yeah. Yeah. Thank you. Yeah. So is the slide visible, sir? Is the slide?
Yes,
Hello?
I'm
Yeah,
visible.
Yes, it is
Yeah.
visible.
Yeah, thank you very much to ISA Aurangabad. At the outset, I would like to thank President ISA Aurangabad, Dr. Sangeeta Deshpande, Madam, and Secretary Dr. Sujata, respected Chairperson Dr. Sujit Sir and Dr. Pramod Sir. It is always a homely feeling back in Aurangabad, and the topic is very close to my heart. This topic, there were many sessions in the recent past, and it was always the area of interest for many researchers, PGs, and even the faculties. So without wasting much of time today, I'll be showing few moves with the use of ultrasound and what it can do. I am not covering the regional anesthesia aspect today, but perioperative ultrasound is always with inclusion of regional anesthesia, because we are in the era of site-specific anesthesia and analgesia. So greetings to you all from my hospital, Ruby Hall Clinic. I have few disclosures to make. I have taken permission from all my volunteers and patients, which also I have received technical assistance from GE as well as from Sonosite Fujifilm for generation of high quality videos. So what is POCUS? So POCUS is, here I am not here to replace cardiologist or radiologist. but I have a question and I need some guidance or immediate answer to save my patient or fine tune my anesthesia. And this is the quest for excellence, and therefore ultrasound, whether it is pre-op, intra-op, post-op, whether it is emergency area, whether it is ward area, it is always handy. Even with corona times, we have used it very often. So the question has to be very specific. It is time sensitive. It is for limited evaluation. It will refine the differential and it will guide treatment. So example, my question is why my patient has hypotension. Uh, am I dealing with pulmonary embolism? Is it full stomach? And should I go for rapid sequence induction? May I get the lumbar puncture in single prick, in even in lateral position for an ICU patient? Or is this patient high risk for DVT? So on and so forth. So you have to have this approach. So it is a fifth pillar now: inspection, palpation, percussion, auscultation, and now insonation. So we'll start with a few areas one by one, and first and the foremost is the lung area. And this was fantastic article by Vincent Chang, where he described this method of IM. So always there is one focus question, which is indication. Then we do focused scanning so that we can have acquisition of desired image, interpretation, and then medical decision making. So this principle can be applied not only for lung, but can be extended in other areas of focus as well. So we basically scan in supine position or in sitting position, and there are different ways of assessment, different scoring system. Different ICUs have adopted 12 point, 18 point, 6 point, but by and large we assess 6 areas: anterior, lateral, and posterior. So I am not going into greater details of lung ultrasound. I'll be touching few basic principles as anesthetist must know. And one of the thing is lung sliding. So whenever we have parietal and visceral pleura, it produces a shimmering effect, and it is seen as a line, white line. And if we could see this line, then it is a sure sign of a healthy lung in that area of interrogation. So if we put an M mode will catch all the motion in that area, and it will something appear like a seashore sign. And deep inside is the sea, calm sea, and periphery, which is the movement of pleura, is picked up as a grainy area and is called as a seashore sign. If we see this seashore sign bilaterally, we probably do not require stethoscope to say that air entry is equal. Now this can be very well used while confirming the placement of double lumen tube. If it has accidentally moved endobronchially, we can always check whether pleura is moving or not. So if there is no pleural sign, am I dealing with pneumothorax? Yes, it is one of the differential diagnosis, but other differentials can be pleurodesis. It could be chemical pleurodesis. It could be fibrotic lung. It could be just loss of lung volume because of complete atelectasis, mucus plucking, or pneumonectomy. Reduced or absent lung ventilation can be seen in apnea, laryngospasm, bronchospasm, and of course DLT placement. So we are open to areas where we have started looking at it, and not only just auscultation, but exactly the area and where we so that we can narrow down our differential. Now there is this evidence to suggest that when we see presence of a lung sliding, then definitely it rules out pneumothorax with 100% specificity at the site of interrogation. Coming to B lines, which all anesthetists must know, and it is something to deal with water logging. So because of any pathology, when the water content of the lungs are increasing, may it be contusion, may it be impending pulmonary edema, we see these white lines. And what are these lines? I'll just show you how they look. These are this was a neonate, preterm neonate with respiratory distress syndrome and having as well as some congenital heart disease. So you can see this white crescentric, white laser-like line starting from pleura going up to periphery. These are all B lines. This is water logging which is happening, and confluence of B line is pathological. More than 3 lines, it is always pathological, and we should check and even we can have a B line score as well for that. All right, coming to pneumothorax, which everyone must know, and because it can happen while doing any regional anesthesia procedure, or it can happen during any thoracic surgery, and sometimes we are just not aware what has happened. So pneumothorax, as you understand, that the shimmering effect of visceral and parietal pleura is gone. So it appears like a barcode, what you can see, and therefore they call it as a barcode sign. Now there is air in between visceral and parietal pleura, so you cannot see any movement, and it is called a barcode sign. Now the import sorry so barcode sign we have seen. So you can see even on CT, the pathognomonic feature of pneumothorax is lung point. So where if you could see this lung point, you can see the movement, the pleura is coming and it is stopping midway and it is not going. So you can see the point where part of the lung pleura is moving and partly it is not moving. So this is called a lung point, and if we get that, it is pathognomonic of pneumothorax. So for detection of pneumothorax, the patient should be in supine position, and so that air will come up and you can scan at least on the anterior aspect. Another area which is important if we want to do a quick scan, so we should never miss this area, which is called as a PLAPS area, that is posterolateral alveolar pleural syndrome, and is just around that posterior axillary line, where we have this highest yield of alveolar consolidation and atelectasis. So what is lung ultrasound is basically a pattern recognition. These are air bronchograms. So we have picked up some air bronchograms with pediatric patient, and we could see that there is a mnemonic patch. And this was during COVID times. People have before HRCT, they have picked up few things and as pathological. And even today, if we see consolidation, I am sure most of us would consider as a high risk patient. So ICU people do serial monitoring of these lesions and decide. Another similar thing is many of our patients do have pleural effusion. We have different formulas, the diaphragm and the pleura multiplied by 20, and noting the amount of pleural effusion. We do tap, and there is a compression atelectasis. So recruitment maneuvers, many surgeries, we want to see whether the lung bases are recruited. So ultrasound is finding its role in this area. We cannot skip diaphragmatic assessment, and diaphragmatic assessment can be with a silent breathing, and it is at this position. Though between it is just by the nipple line, and here is a active sniff test. You can see, so between anterior axillary line and mid clavicular line, and here we are placing the probe so that we can see more of a posterior diaphragm, and we have this active sniff test. Basically we have this inspiration expiration, so we have it in silent position when patient is silently breathing, and as well as in active sniff, and we see what is inspiration expiration, we calculate, and we have now a normal diaphragmatic excursion is 18 millimeter in quiet breathing and 26 with voluntary sniffing. Now, in pediatric population, there is another challenge. Sometimes, because the sternal calcification has not happened in pediatric population, so there is an added advantage when we place a curvilinear probe. We can see the movement of diaphragm simultaneously, and this rules out endobronchial intubation. So diaphragm is moving equally up and down. This is a very good way of assessing. So whenever you have a pediatric patient, make an attempt to use ultrasound in various aspects of focus. So now another aspect is diaphragmatic thickness. There are good validated articles to suggest that when the thickening fraction is less than 20%, then we should not extubate that patient. And therefore, how to determine the thickness aspect? So usually the linear probe is placed in the posterior axillary line, and we tend to see the diaphragm. Now the diaphragm here, you can see the lowest area, and with inspiration there is increase in thickness of diaphragm, and with expiration it comes back to its normal shape. So we have to put an M mode and see how much is the change in thickness of diaphragm, and then we can utilize this formula and calculate the fraction. Coming to gastric ultrasound, it is said that airway ultrasound examination is not complete unless we do gastric ultrasound. Gastric ultrasound is considered as a lower airway assessment. So I am experiencing this many times when previously I used to think that probably 4 hours of fasting is just enough, and why should we follow these guidelines? Are they really correct? 2 standard deviation and 6 hours for solid. And with use of ultrasound, my conviction has increased, because at the end of 4 hours I could still see solid contents in the pyloric antrum, and pyloric antrum solid content, good validated articles now to suggest that it is high risk for aspiration. So we should be very careful. So all the emergency procedures, many times in obstetric anesthesia, either they are full stomach or they are hypotensive, so IVC assessment, airway assessment, even post tonsillectomy bleeding, we just do an gastric ultrasound, we look at IVC, and then plan our airway strategy. So it is a very useful tool. Sometimes there is a dicey history by patients' relatives whenever it comes to pediatric patients. So you can see the anatomy, and this is the pyloric antrum. Whenever it has a liquid content more than 1.5 ml, there is risk of aspiration. Presence of any solid content is always risk of aspiration. So we have this clear-cut flow chart to suggest what is low risk and what is high risk. And I'm showing you a video now.
Initially, I would like to start with gastric ultrasound. So we will move on with gastric ultrasound.
Is the audio, is it audible?
Yes, Amir.
Yes, it is audible.
So what probe I am planning to use today is a curvilinear probe, and it has a orientation marker. Yeah. So most of the scans, I'll either be placing it transversely or in the parasagittal plane. So we'll start with the scanning, and so my probe movement is in the epigastric area. Yeah. So it is from right to left. So what I am trying and doing here,
Some scanning I'll be showing.
Scanning, and what you can see on the monitor. Yeah. So what you can see on the monitor here is the pyloric antrum. So Dr. Rajendra is here to help me today. Rajendra, could you identify the pyloric antrum here? Yeah. So that's the pyloric antrum, and yeah. So we will freeze here. So just freeze with the best shot what we can have. Yeah. So just discussing about the sonoanatomy here. We have liver on one side, we have pancreas on other side, in between is the pyloric antrum, and below is the superior mesenteric artery and aorta. So we can always put a color Doppler to see the vessels and all. So we'll go ahead with the calculations. So yes, so he is using a parameter called tress area, and we are going to identify the cross sectional area. So he's just going to identify the area. Yeah, so he is going to circle it and identify the tress. Yeah. Yeah. So what he has initially showed is the cross sectional area of around 2.31, and in my department we have this gastric ultrasound cross sectional area form which is already available with us, and it is available on any you can Google it. There are multiple papers to show this form, so you can also download it. So on the left hand side it is showing the cross sectional area and age. Now today the age of our volunteer is 40 years, so you can see 40, and cross sectional area around 5, so you can match 5 and 40. So roughly around 49 is the gastric volume. So for practical purpose, any volume more than 100 ml is risk of gastric aspiration, or it could be like 1.5 ml per kg. Presence of any solid content is also risk of aspiration. So we are asking our volunteer to have some water, and as he is drinking some water, we will see how much will be the change in his gastric volume. We are scanning our volunteer after having good amount of water. Maybe he has taken around how much, maybe 200 or 300 ml of water, and you can see the change in the morphology of pyloric antrum. And what we are doing here is again scanning in right lateral decubitus position. So the probe will move from right to left, and we identify the pyloric antrum here. So here you can see again the anatomy, the liver on the right side towards the orientation marker side, and then the pancreas. Lower down is the superior mesenteric artery, and still lower down is the aorta. So now you can see nicely bloated up pyloric antrum, something like gazing star sign, and we can have the best image freezed. Yeah, and we'll do the calculations again. So what we'll do is, you can put a trace down there. So we will just trace, and we are going to make the complete circle of how much is the pyloric antrum cross sectional area, and we have ready-made charts available to identify how much is the volume. There are formulas also to identify, but I think this is the easiest way. We have completed the trace, and as you can see in the left hand side, the cross sectional area being calculated as 35.2 centimeter square. So roughly our candidate or volunteer has taken around 400 ml of little bit of that much of water. So you can see the chart shows the lowest the right lateral decubitus position, the cross sectional area maximum it is showing as 29, ours is 35. So you can pick up the maximum volume, which is around 400 ml. So definitely our volume here is crossing that limit, and it is more than 400 ml. Definitely this volunteer as of now is high risk for aspiration. So this is how we calculate the aspiration risk. So we have to do it in supine position and right lateral decubitus position. The preferred position is the right lateral decubitus position.
So I have done recently one very high risk patient with LCOS, low cardiac output state, and with full stomach, and I was called for intubation. So as per Miller, when we have this low cardiac output state with full stomach, then we did the fiber optic awake intubation. There is some background. Uh, Airway ultrasound. So coming to airway ultrasound is very interesting because uh, many thesis, many difficult intubation pathways where we have. So first and the foremost is the necessity to note what all structures we need to identify. One is a thyroid cartilage, second is a cricothyroid membrane, third is the cricoid cartilage, and fourth are the tracheal rings. So unless we are aware of the anatomy here, we cannot correlate it with the sonoanatomy. So here the cricothyroid membrane is between the thyroid cartilage and the cricoid cartilage. And we must know where the cricothyroid membrane is, because this is the savior in difficult airway. We are nowadays, when we have this type of difficult intubation calls from ICU, we have done the marking here, and even we have done prophylactic placement of a 16 or a 18 gauge gelco with a cricothyroid puncture, and then we have done the intubation drill. So this is an additional safety, at least we can do oxygenation. So we need to identify this black hypoechoic. Number one is the thyroid cartilage, two is the cricoid cartilage, and in between that white mucus line is the cricothyroid membrane, and we can mark it with ultrasound. Even we can do prophylactic puncture also. The philosophy behind this is, many times for high risk patient we do put an art line, and at the end of surgery we just remove it. Now think of a trachea which is very big. Placement of a prophylactic small 18 gauge cannula, when we are really worried about oxygenation of the patient, can be life saving. This can be done in patients with big thyroid, or patients who present with stridor, and where we have to do awake intubation in sitting position, and multiple airway challenges, especially OSA. So this was cross sectional examination. What we can see is hyoid bone, then we can see epiglottis. So behind the thyroid cartilage are the vocal cords. Then we need to know where is the position of cricoid cartilage, and in between the cricothyroid membrane. So hyomental distance is another aspect. We have hyomental distance ratio to note the head extension in flexion and in extension and neutral position. So this is how we assess first in neutral position and with head extended, and the ratio, if it is more than 1.1, then it is with a good neck flexibility. So this is another parameter. One is skin to hyoid bone. So basically with difficult airway, what we understand is there are multiple tools which assess skin to vocal cord, skin to hyoid bone, skin to isthmus, skin to epiglottis. So all these distances, when they are more, it is indirectly suggestive of presence of lot of soft tissue on the anterior aspect of neck, and thereby it is difficult, could be a difficult intubation, difficult ventilation. So this paper says that when we have this 1.4 as skin to hyoid bone distance, then it is difficult mask ventilation. There are multiple articles in obstetric anesthesia where they have seen only one tool, one parameter, like presence of hyoid bone. If it is seen with ultrasound, then probably it's not a difficult intubation. But whenever they have found that hyoid bone was not seen with ultrasound, those were difficult intubation cases. So airway is quite dynamic. Sometimes CT plates may not show the mobility of soft tissue with respiration, and ultrasound is one of those tools where it can do functional assessment as patient is breathing or patient is in stridor. So soft tissues are moving, and the diameter of airway is changing. So tongue thickness, this is another parameter very easy to perform. Tongue thickness at the base, if it is more than 5.8 to 6 centimeter, it is difficult airway. This is pre-epiglottic space thickness. This is another interesting parameter, and again the ratio also is being calculated. So this is upcoming area, and this is another article from 2020 comparative study, and looked at all the predictors of airway, difficult airway and all. And what they have found, the take home message is, we have to combine the clinical parameters as well as the ultrasound parameters of this, the skin to vocal cord anterior commissure distance was quite sensitive parameter, and another was ratio of pre-epiglottic space to epiglottis to vocal cord distance. This another is a very upcoming parameter in many studies. So they have looked at the sensitivity and specificity. So last line shows that when this combination of hyomental distance ratio with Malampatti, with thyromental distance, and this ratio with skin to anterior commissure, it has got maximum sensitivity and specificity. In our day-to-day practice, we do mark cricothyroid membrane. We do see vocal cord movements, and I'll show you the intubation aspect for airway. Also, the prediction of difficult airway, we are doing conducting one study in our department. So we'll just move on to video. So we will see now the airway assessment. And airway assessment, as you all know, can be done either in sitting position or it can be done in supine position. So I have this volunteer and I am scanning the neck in supine position. Otherwise, the ideal position is like you are standing behind the patient and holding the probe in front. So, all right. So I'm just doing firstly a transverse midline scan, and here what you can see is the tracheal ring and esophagus. As we all know, esophagus is usually in the posterolateral position, and here on the left side you can nicely identify the esophagus. The You can ask, I'll request my volunteer to swallow, and you can see the air and the mucosa and the movement there. So it is confirmation of esophagus. So, as per the recent ACLS guideline, now we can park our probe at this location at the time of intubation. So, this is a common practice when my PG is doing intubation, and I want some check over that where the tube is going. So, by placing the probe here, you can directly see where the tube has gone. If it has gone in trachea, you will see double trachea sign. If it has gone in esophagus, you will clearly identify that it has gone in esophagus. So before attachment of any circuit or before any ventilation is introduced, you can very well pick up where the tube has gone. So this is the recent advancement in the airway ultrasound. And because of COVID, people are really into it. They do not wish to ventilate, they do not wish to apply ATCO2 for checking. So with ultrasound you can very well see where the tube has gone. Now coming to the second aspect, which is everyone is interested in vocal cord and vocal cord mobility. So as we understand, behind the Adam's apple, the tracheal, as we scan the trachea up and down, we identify the prominent Adam's apple, and behind the Adam's apple, we see vocal cords. The vocal cord movement. So this additional point is if patient has got a prominent Adam's apple, the ideal position would be to put the probe in the cricothyroid membrane and just give a cephalad turn so that you can very well easily see the vocal cords. Is bilateral, as you can appreciate here in this volunteer. Uh, Somewhere lower down, you see some hyperechoic dot. Those are arytenoids, and you can see the movement of arytenoids bilaterally equal. So if you have a vocal cord palsy, the movement of vocal cord may be unequal, and this is useful in patients post thyroid surgery or any patient with previous history of hoarseness of voice. We would like to do a pre-procedural scan. Sometimes you may pick up an incidental finding like vocal cord polyp in an absolutely asymptomatic patient. And if we could note that there is a vocal cord polyp, then we can be very careful in avoiding trauma in that case. So vocal cord movement is useful sometimes even with interscalene block. There can be recurrent laryngeal nerve palsy. So at the end of thyroid surgery, we usually place the probe and see for vocal cord movement. And vocal cords are best seen if they are waterlogged. So usually near extubation, there is some amount of edema with larynx, and that is why they are seen better. In this volunteer, I have just given him some sip of water, and because of which the visibility improves. You can also see the vocal cord in long axis. Now here I am just scanning above the Adam's apple. So the important structure above the Adam's apple, what we are interested is, one is epiglottis and second is hyoid bone. And higher up, we can go for tongue thickness. So here I'll just above the Adam's apple, I am looking for epiglottis. And epiglottis is classically seen as a horizontal black hypoechoic area. Sometimes in patients with H. influenza infection or those who have bigger epiglottis, you can see the diameter is more, the thickness is more. So here I am going to look at one calculation, that is skin to epiglottis distance. And here the skin to epiglottis distance is around 1.44 centimeter roughly. So the cutoff value is 1.85. So any value above 1.85 is difficult intubation. So actually, with difficult intubation, different measurements have come, like skin to vocal cord distance, skin to hyoid bone distance, skin to epiglottis distance. Then they have looked at the different ratios as well. By and large, if the thickness is more on the anterior aspect of neck, the intubation will be difficult. Now here is a long axis view. In this long axis, we can see tracheal rings, we can see cricothyroid membrane. So at the orientation marker, there is the thyroid cartilage, and here is the cricoid cartilage. In between is the cricothyroid membrane, and lower down are the tracheal rings. So near the orientation marker is the thyroid cartilage, and below is the cricoid cartilage. In between is the white cricothyroid membrane. Lower down, we can see tracheal rings. So if we have placed a tube, it is good idea to inflate the balloon with saline so that it becomes hyperechoic, and we can see the balloon here and where it has gone. If it has gone beyond third tracheal ring, probably we are dealing with endobronchial intubation. So in this view, the important thing is identification of tracheal ring, and secondly, the cricothyroid membrane. I have used the scanning part to help my ENT surgeon also for deciding the place for tracheostomy, and we can put a Doppler, we can identify vessels and help them with the incision. This is useful in patients with post modified neck dissection and scarring. Now here I am assessing the tongue thickness, and it can be done at the base of tongue. And you can see, as I have put the marker there, the measurement is 2.97 centimeter. So any measurement more than 6.1 is huge tongue, and it is difficult laryngoscopy and intubation. So that is another parameter which we have looked at. The third parameter which I am showing you here is for neck mobility, and we can calculate the mento-hyoid ratio. So mento-hyoid ratio, first the distance is calculated from the inside edge to the inside edge from at the tip level, and then this is in neutral position of the head, and then the patient is asked to extend the neck as far as possible. So in extended neck position, again we have to calculate with the help of caliper the mento-hyoid distance, and we look at the difference between two. So with extension, the length increases. So if the difference is more than 1.1 or 1.2, then it means the neck has very good mobility. If the distance is less than 1.1, it means mobility is less and it could be difficult intubation. So this is another criteria for difficult intubation when we look at it. So apart from the movement in flexion and in neutral position versus that of extended neck position, we can also look at some of the parameters, like if you have a linear probe or a curvilinear probe with COVID, we can put it over the maxillary sinus, and I'll show you. Usually, if we place the probe over the maxillary sinus, we do not see much of any hypoechoic area or something. But if patient has got maxillary sinusitis, then we tend to see. Now I'm placing my probe over the maxillary sinus. So there are clear-cut hypoechoic area, fluid-filled sac. That is indication of maxillary sinusitis. And if we so presence of maxillary sinusitis is a relative contraindication for nasal intubation. We may tend to push the infection posteriorly. So it is not a good idea uh, to do intubation, nasal intubation, especially if patient has maxillary. All right. So, coming to neonatal aspect and airway, I have few tips if some of us are doing pediatric intubation. So, when we do term neonate, so the rule of thumb is when this is the tracheal bifurcation and 1 centimeter above the tracheal bifurcation is the tube end of the tube should be. So, but how ultrasound can help us? So we can place the probe in the parasagittal plane, usually the just by the side of sternum, and we can tilt a bit, and we can see arch of aorta. Now we have to understand the relation of arch of aorta with the division of bronchus, primary bronchus, right and left. So if the tip of the endotracheal tube is seen above the arch of aorta, then probably it's not a endobronchial intubation. And this was being reported, and people have calculated the distance between the right pulmonary artery and the tip of ET tube. And those who are interested can follow the articles regarding this. But with use of color Doppler, it is easy to identify arch of aorta. Now, even in neonates, we are called for lumbar puncture, and there are good studies to suggest that when it was done blind, there are multiple echogenic hematomas. And nowadays, it is desirable to do it with ultrasound. We have done it for a sick baby, and we have even placed a intrathecal catheter. This was a preterm neonate, and with a lot of infection, finally cerebral infection, and cholesterol was given intrathecally, and it was for 21 days. We continued this patient monitoring with CSF and culture and everything as guided by our pediatrician. And this was during COVID times, during the first wave. Uh, as I was mentioning, pediatric patients are very wonderful patients for focus examination. And you will see this was Kasai procedure, and we have placed an epidural catheter caudally, and it was advanced till T7 level. We can very well see the catheter as well. Before closing the, this cannulation and other parts is nowadays I'll tell you, when I was working in my previous institute, I was in Hinduja Hospital, and there was a good amount of workload. So my track record of quickly securing an radial arterial cannulation was very good. But as you progress with age, there are different multiple OTs. You don't do that many cases. But even with ultrasound and this use of ultrasound, you can still finish the procedure with the same accuracy, and your strike rate will not change, and you are so happy about it. Finally, when you are inside OT and you have to induce a high risk patient, there is always time which is ticking, and you can deliver it if you are good with that. So this is one technique I am explaining. And radial artery, because they have very thick tunica media, so attachment of this 2cc syringe, we remove the piston, we see the clear flow. It is out of plane, cannulation. And once we are seeing the clear flow, we just advance the cannula. So this is cheaper than a Seldinger technique, where the cost of Seldinger catheter is there. You can do it in plane also. When it comes to venous cannulation, it is a little one level up skill, I would say. What we have to understand is the anatomy. So we usually place the probe transversely, and we scan the whole of forearm for all the veins and how they move across. So we know exactly the path of vein, whether they are moving from medial to lateral or lateral to medial. And usually we aim at cephalic vein, and it is in plane technique because out of plane could be challenging for cannulation, and it is with a good success rate. You can see the cannula going very well inside, and many students, mostly when we are doing this, we usually choose a long length 20 gauge cannula, and we are even called for this procedure to ICU when they are not getting any IV line. IVC aorta ratio, pediatric population 0.8 to 1, 1.2, less than 0.8. Probably we need to give fluids. More than 1.2, no need for fluids. Cardiac index is more validated parameter. And in neonates, especially term neonates, I found this another interesting article which suggested what we talk about adults and IVC collapsibility, that is 50%, but here the diameter is one number they have given, it is as 8 millimeter. So in term neonate, if the diameter of IVC is more than 8 millimeter, they do not require fluids. If it is less than 8 millimeter, they do need fluids. So I was just talking about these B lines, and I have already shown you this video. Now, nowadays these B lines, it is useful to differentiate between transient tachypnea of newborn versus respiratory distress syndrome. So this is a new thing where, in respiratory distress syndrome, we will get confluence of B line all over the chest, whereas in transient tachypnea of newborn, they are mainly limited to basis. So this is how we can differentiate it. Also, nowadays, there are validated studies to titrate the dose of surfactant. So if you give a adequate dose of surfactant, there will be disappearance of B lines and appearance of A lines, and lung becomes normal. So once a baby is delivered and they are in distress inside OT, if you have ultrasound, it is good idea to just place a probe and guide your pediatrician. And if they are interested, then you can have a fantastic discussion. We do get calls when we are part of pediatric PICU team, and they tend to put umbilical vein cannulation when sometimes there are challenges. So umbilical vein cannulation, you can see that ductus venosus, presence of ductus venosus, and then IVC. The umbilical vein catheter may sometimes enter the portal vein, and then there are multiple shoots with the neonate for confirmation whether it has gone rightly in or not. So you need to know the course of ductus venosus, and so with use of ultrasound, it becomes very handy. And nowadays, our radiologist, our pulmonologist, our pediatrician, and intensivist, we have formed a team, and all of us are interested in POCUS, and they give us many inputs. We share inputs, and they are also happy with our inputs from OT, and we do scan and discuss. So ECMO cannulation, I am sure some of you may be doing pediatric anesthesia, cardiac anesthesia, and confirmation is very, very useful. We have been called to PICU for drainage of hydrocephalus, obstructive hydrocephalus, and neonatal intraventricular hemorrhage is always a problem. We are exploring this area. I have scanned these babies with a lot of hydrocephalus, and we have seen this hematoma. Our PGs from PICU are very much interested. There are transcranial Doppler is also useful for detection of vasospasm in adults. And nowadays, when we do neurosurgical patients, some of them have already had this craniotomy done, and so we have a good window, and it is easy to put a probe. So we have placed a probe in patients with cerebral abscess. You can very well make it out. I have even placed it for a patient with bullet shot injury, and bullet was nicely seen in the brain, and I could guide the surgeon. Another aspect with neonate is something like command hospital, or where the anesthetist is the sole physician and ANC patient coming for the first time. Placing a probe in the lower abdomen, you can easily pick up placenta previa and what is the presenting part. And this will save the life of patient, because then you can gear up accordingly. And sometimes in government hospital, they might not followed up with regular ANC checkup and all that. So presenting part you can pick up, and it is not a rocket science. It's a very easy skill set Cord round neck is always possible. These are some photos and videos which I could get with the help of my radiologist friend from Ruby. And I'm sure if you have this sort of idea, you can always plan. So even this cord round neck, I can tell my pediatrician that see there are multiple cord round neck, and be ready with your gears for resuscitation, and they act accordingly. Basic TT, you are, if you are interested, you please do and complete the course with basic fit, which is with PICU Foundation, Dr. Desurkar from Dinanath, and we are conducting workshops on regular basis. And if you are interested, you're all welcome. So, is skill set necessary for a non-cardiac regional anesthetist? Yes, it is now a evidence-based statement, a review article showing how focused cardiac ultrasound can help regional anesthetists. And what is most important is we must be in the position to pick up at least pulmonary embolism. We have picked it up in patients with radical robotic prostatectomy. Otherwise, most of the time, PE is an autopsy diagnosis. Cardiac tamponade, yes, it is a life-saving situation. We cannot wait for cardiologists to come and help us. Massive MI can, if we could detect with ultrasound, it will change our treatment. It will guide us and fine tune our management. Severe hypovolemia, looking at IVC, pulmonary edema, pneumothorax, all this is very, very useful and life saving. So these are fate cards, these are available also. We'll just see one video for IVC now.
4-chamber, and we can see RA, RV, LA and LV. So we can see the pericardium. We are going to see the heart through liver. The interface between the liver and the heart, there we look for any pericardial effusion, cardiac tamponade, things like that. So this is a very good view to pick up any effusion, any tamponade, and even we can watch the early tamponade physiology, where you have a furious right atrium and the contractility. So now I am turning my probe in 90 degrees anti-clockwise to open up IVC, and here is opening up of IVC. I can show you that IVC has opened up here. So we measure IVC at around 2 to 3 centimeters away from RA. So from RA you can see. So there is a button called as auto IVC. So we are pressing on that, and it automatically picks up the algorithm. Now there is a manual override also. So that is how you can change the location also. We have done this calculation, and this auto IVC measurement, here you can see it will tell you about the minimum diameter which happens with inspiration and maximum diameter at expiration, and it tells you about the collapsibility index. By and large, if diameter is around 2.1, it means the IVCs are absolutely full. Here you can see the maximum diameter around 19 and a minimum of 4, minimum of 7, and collapsibility index is more than 50. So this patient can be given fluid challenge very well.
So there is another utility of this view, and which we use it very regularly, and that is called as a swirl sign. So when we put a central line, we inject saline, and we can always see the movement of micro bubbles, the agitated saline from RA to RV. If this is happening in less than 2 seconds, then we must be very sure, we are very sure that that the central line is correctly in position. And if it is more than 2 seconds, then it might have gone in any of the axillary vein, or gone on the opposite internal jugular vein. So it is good idea to scan the opposite side neck and also the axilla on the side. So this is we document this, and we put it on paper that with limited echo study suggestive of positive swirl sign, and we can avoid X-ray in this patient, and we can use this line very safely. Okay. Just seen the IVC assessment, and now we are slowly moving to see the apical 4-chamber. Okay, we have the
it. So could you explain what all the structures are, Jay? Yeah. So we have.
So this is a apical four chamber. We have on the orientation marker side the left ventricle and the left atrium, and also we have RARV. So this basic view can tell us how is the contractility, how is the fluid status. If we put color Doppler, we can see if there are any issues with valves. And even this basic eyeballing, it gives me confidence whether I can induce this patient or not. If I see regional valve motion abnormality, heart not contracting well, then it will help me in changing my strategy of induction or spinal anesthesia. So even though the patients are with echo report, we do a pre-procedural scan, and it is nowadays whole of my department has completed basic FATE course, PGs, consultants, and SR. And there are other areas like TAPSE for assessment of right ventricular function, MAPSE for LV systolic function. This you will definitely pick up with good FATE course. So I think it is nowadays an essential tool. uh, I'm just showing
Long
the
axis
other
here.
views as well, the parasternal long axis and the short axis. So where the probe should be, it should not be lower down, it should not be elongated, other final tips. But it gives a very good advantage to me when I'm dealing with these patients. Most of them are critically ill when they are for regional anesthesia. So this is an additional tool. I can calculate EF, I can pick up quickly pulmonary embolism, cardiac tamponade, pneumothorax, and even regional valve motion abnormalities. So it is nowadays a very good habit that we correlate the echo findings mentioned on the file with our own echo, and this is helping us to gain confidence. So you may not get all the windows very correctly, but even one window is enough. At least you have looked at contractility, IVC assessment, and advanced echo studies will tell you how to calculate PA pressures and things like that. So I think with this we'll move to ultrasound spine, and this is perioperative excellence, because nowadays obstetricians are telling us, please give us provide us with that single shot spinal. Many patients have told me that if you can do spinal in one go, then please go ahead with spinal, otherwise give GA. So for all these C-section patient nowadays, this is an added advantage. And in my own practice, I do spinal and epidural with ultrasound assistance, and for each and every patient. So you will be surprised if you start scanning each and every patient, you will develop your own understanding. And so my focus question for spine ultrasound is, please tell me the point where I should put my needle so that my accuracy, my precision, or my success rate is maximum. Is the needle, that 8 centimeter, 9 centimeter needle, enough for this patient? And or should I change my equipment gear? So these are some simple straightforward question. Tell me the level where I should put my epidural so that I have better quality of analgesia. So most of the time we think that this is L1, L2, or this is T8, T9. It may not be like that. So with ultrasound, we can actually make it congruous and more scientific, because we know. So how we have moved ahead with this is with good use of training on phantom models, and we have the spine bone models are available, and you can utilize it, and you can do the needling part as a part of training. And even we are using it for our fellows one session, and previously it has given us a lot of confidence with over these spine models, like where the needle has gone, where it is seen interlaminar space. There are good articles if you are interested. So different spine models you can procure for your own department. This can be another thesis topic. Ocular ultrasound, optic nerve sheath diameter, this we are using it for radical robotic prostatectomy, major laparotomies more than 5 hours, and even in neurosurgery patients where they have raised ICP. So just before extubation we do this, and if the diameter is more than 5 millimeter, then probably we give Lasix, we delay the extubation. This because this is an indirect method of assessing ICP, and it is very easy to do. So where we do it, so we see the optic nerve 3 millimeter behind the globe. So this is the area. Why 3 millimeter? Because subarachnoid fluid is the CSF is equitably distributed at this juncture, and if the diameter is more than 5 millimeter, then it is raised ICP, because optic nerve does carry all the meninges with it, and it is a very easy way of non-invasive ICP monitoring. Another thing is we have started using Doppler for this, and we can pick up pulsations at the base and near the optic nerve. Optic nerve sheath diameter is one parameter, and another is vessels if they are not pulsating. So with COVID, there were like 16 hours of prone position ventilation, or scoliosis surgery. So pre-procedure we document that arteries are pulsating, the central retinal artery, central retinal vein, and they were all documented, and post-op also we document it. So this is another way when we are worried about POVL, post-operative visual loss. So this can be another parameter. Sometimes patient may have black eye and we cannot check pupil. So there is a consensual light reflex. So if we put light on the other eye, and this is the eye with tegaderm and with an ultrasound probe, and we are putting the light in the other eye, and you can see the pupils are constricting with light reflex. So this is useful when we have black eye and we want to see whether pupils are reacting or not to decide with the surgery. Bladder ultrasound is absolutely essential when we are talking about fluid management. Sometimes we give a lot of fluid and no urine. The catheter may be blocked, so we just have to see with how is the bladder, and there are ways to assess bladder assessment. Now we have POCUS workshop in AORA. You all are welcome. We will be giving hands-on and we'll be teaching how to do it. So please join us for this workshop. We also have workshop in GARC, so here you can see the ureteric jet. So urine is coming. So post kidney transplant, you can see whether the right kidney is functioning well or left kidney is functioning well, and you can see how things are. There is another aspect is DVT scanning. I have few videos, if time permits we'll see, but this is another interesting area where you need to know the anatomy of femoral vein. Where is the great saphenous vein, where is the superficial femoral vein, deep femoral vein, and popliteal vein. So there is a 3-point compression system. If at 3 different points, one at the common femoral junction, the great saphenous, the superficial femoral, and the popliteal, if they are able to see nicely compressing vein, then probably there is no DVT. So here you can see the DVT is like this, where it is not able to compress the thrombus. The thrombus is appearing as a hyperechoic area. So pre-procedural scan, especially in orthopedic population where we have not done lower limb Doppler. So before giving spinal, all those octa and nanogeriatric, I do this scanning. It gives me confidence that I am okay to give spinal. And abdominal E-fast and rush, I think I'll just share this last video. So to close my presentation, so rush protocol is basically rapid ultrasound in shock and hypotension. All these POCUS interventions are not replacing any CT scan or any definitive investigation, but in the meantime, it can quickly guide you with diagnosis and treatment. So it is a mnemonic of HIMAP, HIMAP. H is heart, I is IVC, M is Morrison's pouch, A is abdominal aorta, and P is for pulmonary area. So I'll just share this last video and we'll close with this. So I think I have that video. Let me see. Just give me a minute. So this is the last video of E-fast.
Here we are doing an E-fast. So I'm going to assess in the the right upper quadrant. So what structures you can see here? First is the liver, then there is a black shadow of rib, and ahead is the kidney. That's the kidney, and inferior pole of liver, inferior area of liver. And so in between the liver in between the liver and the kidney. Yeah, if there is any free fluid, if we tend to see hypoechoic area, fluid collection in that area. So that is the significance of this scan. If we have any free peritoneal fluid, we will see fluid over there. So just enter no. So we have not seen any peritoneal fluid collection. Now you can get rid of this rib by turning the probe little obliquely and getting yourself aligned within the rib, so that you don't see the rib during your scan. Anyways, now I am going on the other side. Again, the orientation marker I am keeping on the, so this is a scan on the left side, and again we tend to see the spleen here and then the kidney. So you can see again the area, my area of interest is between spleen and kidney. So yeah, so there is no fluid collection as such in this area. You can see this very nicely. So between the kidney and the spleen there is no fluid collection, so you can mark it as no. Yeah, fine. And now we are moving as a third step in the epigastric area. So increase the depth. So you can actually use, make it 20 or something. Yeah, so you can actually use the same probe even for assessment. And so what you can see is a nicely contracting heart, and there is no pericardial fluid or effusion or tamponade physiology. Where we identify the fluid, just show them. Yeah, between the interface between liver and heart, sometimes we tend to see hypoechoic fluid collection. So mention this area as no. So this is documented. Now we are going into the position 4 and 5. Position 4 and 5 are actually for bladder assessment, and here we see the full bladder here. And the best, if I have to assess this area, then the best position would be long axis view, and that's the long axis view. So we keep the orientation marker cephalad, and we see the whole of bladder. So actually the bladder size is big. You can change so that we can accommodate whole of bladder. So here the orientation marker, what you can see, the orientation marker is cephalad, and I am watching behind. So I am just watching behind the wall of bladder. So what I am seeing here is a rectum. So it is a rectovesical pouch, and there is no fluid collection. So just posterior wall of bladder. Yeah, so there is no hyperechoic area behind the bladder. So you can see a clear cut distinct line, otherwise there is a fluid collection. In female patients, it can be uterus down there, and we can see in the vesico uterine pouch there can be collection. So put no for bladder, yeah, store. So now after this we are going for, we are going for the stump, for the lung area, and in the lung area there are two areas. Now we have to assess the patient in supine position. Reduce the depth please. So we have to assess for the pleura, and what we can see here is the pleural lines. We can actually change the probe, change it on the linear probe. There is one more function which is available. Go on eFast please. So go on eFast. So there is a, already it is on eFast. So now you can use auto function. Can we have the auto function here? Auto B lines. Can we have auto B lines here? In the application, can we have auto B lines in the lung? Yeah, so we can have auto B lines. Yeah, so you can utilize this function. If there are B lines, they are picked up with as auto B line, and it will give you a ready-made score of auto B-line score. Lines more than 3 and 5 can be pathological. As they increase further, it is impending pulmonary edema, waterlogging, ARDS, so on and so forth. So routine monitoring of B-line scores is a good idea. So here we can do it on both sides. Also the lung sliding, we can also put an M mode. Put M mode one more time. Yeah, one more time, press it. So yes, so this is a seashore sign. The distal one lower down is the shore and deep inside is the sea. So this is a normal moving pleura and this is a normal seashore sign. So this indicates that this is a very good functioning lung and there is no pneumothorax. So now put no for both right and left. Yeah. Yeah, this is also no. Put it as no. We have assessed both areas. So at the end of our quick E-first, we can see all the views. So you can see that the views we have recorded, and this is how we complete our E-first. Okay, come on 2D. So when it comes to rush protocol, so the commonly used mnemonic is high map. So H stands for heart. H stands for heart, and we see the heart here. So there is no pericardial effusion. Increase the gain, please. There is no pericardial effusion. The size of LA and LV we can see, and we can rule out no pericardial effusion, no pulmonary embolism probably, because the RA/RV is not dilated. And also we have looked at IVC, so we can actually check for IVC with this also. So we can open up the IVC. The probe of choice for this is probably a phased array probe, but you can still see IVC. We have done the measurements already, so IVC and its movement with respiration we can pick it up. So this is heart of high map. I is IVC. Then M is again Morrison pouch, which we have already seen how the Morrison pouch will look, and where is the kidney and collection of fluid. So that is for high map. So if there is any fluid collection, you can pick it up. A is aorta. So here we put on the middle of the abdomen and we see aorta. So aorta is a structure in the center, circular and pulsating. So that is the pulsating aorta for you, and you can see the aorta nicely pulsating. As you are seeing the aorta down there, yeah, you can calculate the diameter of aorta measurement. Yeah, only that's fine. So yes, one point to other point. Yeah. So inside to inside, and if it is more than 3 centimeter, it is probably aortic dissection, aortic, there can be pseudoaneurysm. So here it is 1.38. So anything more than 3 centimeter is definitely pathological. So this is in that high map. We have seen H for heart, I for IVC, M for Morrison's pouch, A for aorta, and P is again for pneumothorax. Pneumothorax assessment is always done in supine position. If we see pleura, the sliding pleural sign, then it virtually rules out presence of any pneumothorax. The pathognomonic sign for pneumothorax is presence of the lung point. All right, this concludes our examination of POCUS. Thank you very much.
So thank you very much. I think we have completed that, and I'll be more than happy to answer a few questions. I tried sensitizing you with different areas of focus. There are multiple, even advanced areas but I'm sure there are many scholarly viewers also. They may be doing more than what I have been showing, but I'm sure something or the other everyone must have picked up in some areas. There are few videos with DVT and other things, but I think we'll stop now. And thank you very much for this opportunity. Over to Bhale sir and Sujit sir if some questions are there. Thank you.
Thank you, Amit. It was excellent presentation, and you have enlightened us not only one but more than 10 aspects of ultrasound which can be used perioperatively in operation theater as well as in post-op in ICU also. Ultrasound is a safe and portable, and it is relatively inexpensive. But I think it is not accessible to every anesthesiologist. Like you are working in Ruby Hall Clinic and many anesthetists who are working in multi-specialty hospitals, they usually have ultrasound machine in operation theater which is dedicated for anesthesia. But even today, I think most of the government medical colleges or the institutes don't have ultrasound machine available to their residents and anesthesia students. But I think this is the high time that this focus curriculum should be incorporated in anesthesia training program, so
Yes.
that every anesthesia resident should get hands-on with ultrasound, and then definitely it will benefit to the patients. That Dr. Kobal and their colleagues, they conducted one study where they compared board certified cardiologists uh, with uh, the first year medical students. And these first year medical students were given minimal training for the focus to diagnose the cardiovascular pathologies. And to their surprise, they found that these medical students outperformed these certified cardiologists who did only physical exam by almost more than 25%. So, as you rightly said, and you have shown many videos which were really wonderful teaching experience for learning experience for all of us. Now, I think this session is open for question, and I would like to ask my first question to you.
Yeah.
You said that in difficult intubation scenario,
Yeah.
you put gelco through ecothyroid membrane. So I would like to know how you connect oxygen to this gelco and how much flow you give through that gelco cannula.
No, this was, I mean, this thought was shared with us. This was a personal communication, and one of the aggressive researcher in this area is Dr. Pankaj Kundra, and that was his sharing with us that when we compare a radial artery cannulation versus that of a big trachea, so we are not harming the patient. So now we previously we have this CVCI, cannot intubate, cannot ventilate guideline, and now it has been changed to CVCO. So now concern is oxygenation. So if we put that 16 gauge gelco and we connect our 2cc syringe, and we can even put a connector how we have been trained in government hospitals to use the cricothyroid set. I mean, mostly when I have done this, it has provided me little additional time for my awake fiber optic intubation before patient has desaturated. So this was one case which I recollect. I was called in ICU. Patient was with laryngeal pathology, and he was in tremendous stridor, and they have placed a BiPAP mask for 20 days. So when the fiber optic was passed, I could see nothing but black dark webs, and then I have to negotiate. And when I have reached the larynx, and already we have placed this cannula, a 16 gauge cannula, and oxygen was connected. It has provided me one, or I could finish my job in 1 and 2 attempts, just because somehow oxygenation was around 80, 85, and little additional thing which we could and of course there was a standby ENT surgeon with me, and he was also very much worried because the neck was too thick, and he couldn't feel any anatomical landmarks. So it was already a guide in place if require emergency surgical tracheostomy. So I think how to use it is left to our innovation. But one point where we can see, and it has already been marked, because once airway trauma is aggravated, it is a very tricky situation, and sometimes we may lose the patient, and we do not want to be, we want to be one step ahead. Once the suction bottle is filled with blood, nothing can be done much about it. So I mean, we have found that yes, it gives me little bit more confidence if I do it beforehand. Another point which probably I have not covered is we can calculate the diameter in the subglottic area in a transverse scan, and we can decide about the size of tube also, looking at the internal diameter of trachea. So this is useful in pediatric population and also in patients with difficult airway. So I mean, you may have more and better advanced ideas, but yes, as we are worried about oxygenation, so this is one axis which we thought can be useful.
How much oxygen flow we can connect to that gel canal? Maybe 4 to 6 liter per minute.
Yeah. Mostly, we have to apply one assistant with this, because that patient usually tends to have a lot of difficulty in breathing, so they tend to move, and therefore, unless the cannula, because we remove that stillet, so they tend to kink a lot, and sometimes these patients are with a lot of secretions, so they are subject to occlusion also. So by if we have attached an ambu bag, we have even ambued through that. So you can always attach a 2cc syringe to that gelco, and to that 2cc syringe a universal connector of maybe 6.5 or 7, and then that assembly we usually check, and then you can attach an ambu bag, and you can force in oxygen into that. So this we have done, but then one person for ambuing and another to hold the neck of the cannula, because it tends to bend and it produces challenges like that.
Okay, thank you, Amit. My next question is, in high volume centers, actually you are working in Ruby, so
Yeah.
definitely it is a very high volume center. And my team where we work in Aurangabad, most of the hospitals are very high volume centers where turnaround time is very less. So
Yes.
you have to do your procedure very rapidly. So you
Correct.
said that for every spinal you do screening and you decide your puncture point. So definitely I would also like to do that, but how you manage the time?
Yeah, so this has been the teaching and training of regional anesthesia. Regional anesthesia was always with an allegation before I joined my fellowship in Ganga. It was like surgeon would say, "वो तुम्हारा 2 घंटे का block," something like that. They will always do that. You sciaticofemoral block, you will take 2 hours, and my surgery is only for 15 minutes. So this has always been a challenge, and now we have reached a stage with arrangement. So before the patient is wheeled inside, so if it is a regional anesthesia case, we arrange the ultrasound machine, the probe, the ergonomics. If we are doing a block, then already the probe preparation, the stock solution, and the needle and the candidate is ready. So once it is taken inside, it's a teamwork. One person will attach monitors. We may give minimal sedation to reach a Ramsey score of sedation score of 2 or 3, and then immediately with local anesthetic, and we'll start the block. So similarly, this is what our topic today is: need for excellence. So this is one thought which came to my mind, and it presses me, is if I can give and finish this spinal anesthesia in a single prick, is it justified to give one or more pricks? Because you will appreciate with your experience, one cannot say in which patient we end up with 8 and 10 punctures, because apparently back and everything may look normal, person may be thin lean, but this pre-procedural scanning we are sure. So if we see posterior complex and anterior complex very well, then we are sure about the block. So I'll mark the point, and it is done in single prick. And if it is not there, if it is already a difficult spine, then I will do only 1 or 2 attempts, because there is evidence to suggest that if you cannot see anything, it could be because of artifact, and the performer should reduce their threshold to conversion for GA. So in those patients, when I find that back is really difficult, I can't see anything, either I go up or down. or I already informed the surgeon. See, I have shown even some of my patients were radiologists themselves, microbiologists themselves. They have reported me, I have a mild scoliosis, this and that. So we have planned it accordingly. So we tell them that your back is really difficult and I'll try once or twice. Otherwise, we'll convert to GA. So it saves time, it saves agony, and all these patients are much more happy with this approach.
Thank you, Amit. I will try to incorporate this practice routinely in my hospital setup. Thank you. I hand over this session to Sujata.
There is one more question in the chat box. Can I read that? Hello?
Yes.
Am I audible?
Yeah, there is echo a bit.
Yes.
Yeah.
Am I audible now?
Yeah. Yes.
There is one more question in the chat box.
तर तुमचा हे बंद करावं लागेल, म्यूट. Okay, I got the question. I think it's in the chat box.
Yeah.
Fine. So I'll give the answer to that. So something about pulmonary embolism and the pathognomonic sign and all that you read about McEwen sign and that shimmering apical and lateral right lateral where there is no movement, and that is pulmonary embolism with dilated RA-RV. And so what we have found is at least in one of the views, either apical four-chamber or subcostal four-chamber, we have found this dilated RA-RV. So this was one of our patient with radical robotic prostatectomy. Surgery has started well, and suddenly patient had a severe profound hypotension, and then it was a VIP patient. So many people were inside OT, and cardiologist and intensivists, they were at our OT door. And then we got this ultrasound machine, and we have just scanned, and we could see that RA-RV was dilated. It was probably something like CO2 embolism, and we could share those images and videos with our intensivists. And what the statement they made is anesthesia is all perfect, and we will manage this patient. Anesthetists are doing fantastic job. So it was we were also sure about the diagnosis, so we supported the patient. Patient did well with fluids and inotrope, and on third day patient got extubated. So it gives us a lot of confidence when suddenly some hypotension has happened to a patient after spinal anesthesia. Am I dealing with anaphylactic shock, or am I? So we even do pre-procedural scan of IVC before giving spinal, and so that we can prevent hypotension, and how much fluid we should give if there is severe hypotension, that also can be very well guided in. And then we scan for B lines and bladder, and we complete. So I mean, it's a very useful tool, and it gives you at least the three important heart condition. One is pulmonary embolism, second is cardiac tamponade, and third is severe MI. This can all lead to death. So at least if we could pick up any of these diagnoses, we can fine tune our management, and we can save the life of our patient. So that was in the RUSH protocol, where you do rapid assessment with ultrasound for shock and hypotension. Thank you.
Any more questions? Varsha, are you there? Varsha?
Yeah.
Is there any more questions? You can have it that we can have that in the chat box, or you can unmute yourself and ask the question. Anyway, Dr. Amit, can I ask one?
Yeah, please.
In head neck cancer surgeries, where you have the CT done of the patient, some of the other time you have a good mouth opening, say about 2 finger. If the mouth opening is less, we predict it as a difficult airway. But if the mouth opening is good, many a times me land up in difficult intubation because of the growth extending beyond the same. And during laryngoscopy, there is a trauma, bleed, or and make the intubation procedure messy. How can we pick that in the ultrasound?
Yeah, what ultrasound and the focus is changing us is uh, any investigation or any interrogation is considered as a useful interrogation, provided it helps us in changing our plan of management. So this has happened to me several times when I have seen echo or I have seen airway. First thing I have done is I have asked for additional help. So I am anticipating that there can be some problem. So most of the time when it comes to difficult airway assessment, we do all the scanning which I have shown in video, mainly the thyro, the mento-hyoid ratio for neck flexion extension. Then we do skin to anterior commissure, skin to epiglottis distance. If we could see hyoid bone, that's it even a better sign, because sometimes people have used it as a single tool. And then we also look at the subglottic and the tracheal area. If how much is the diameter? Sometimes these unanticipated difficult airway can have subglottic lesions and lymph nodes where they have landed up, and it was found on autopsy as CVCI. So tracheal diameter will also help me in some patients with tracheomalacia. We assess the diameter and then we inflate the ET tube cuff. And if the difference is not more than 1.6, then it is also a good thing, because otherwise if it is more than 1.6, the difference with inflation deflation, then it can land up with post extubation stridor. So this is another problem. So I mean, you have to use clinical parameters. You have to combine, as I was showing in another article, you have to take into account all these ultrasound parameters in conjunction with your clinical assessment. I'm sure if you are doing it pre-op, it will definitely help you in detecting that this could be difficult airway, though the area is emerging, because airway is quite dynamic. So if you have a thick tongue, if you have this skin to epiglottis, skin to the vocal cord distance reduced, or hyoid bone not seen, then am I dealing with a difficult airway? And it is always good to be safer and then to be sorry. So I always tend to involve more help. We improvise on gadgets. I would ask for a video laryngoscope. I would keep standby things with the fiber optic intubation or an LMA and a difficult airway crash card. So this has changed my management in the way that I am more geared up to handle any eventuality. And I think this is enough, because it can save our patient instead of landing up with an unknown terrain where we don't know what is happening to our patient.
Thank you, Dr. Ahmed, sir.
I have answered your question.
Yeah. One more thing. If we have the tracheostomy done, and many of the time in the ICU, there is a tracheal tube blockage, somewhat like that.
Tracheal tube
Block.
block.
So can we detect that on ultrasound?
Tracheal tube block, yes. So you have to correlate with a parasagittal scan as where the tracheal tube has gone. You can always use a guide, something like a stellate or something which is hyperechoic. Which type of trachea tube is there, whether it is a metal is good for ultrasound, but if it is a regular tube, then try to inflate the cuff with saline, maybe, because saline is hyperechoic and we can see. Then those secretions and other things, you can also do a quick scan for lungs and which lobe, and accordingly. So even for demonstration purpose, I have placed the bougie in Rile's tube. instead of Ryle's tube, I have placed a bougie in esophagus, and that also can be very well seen. So sometimes you can use bougie or stellate where it is going and what is happening to the patient. So block tube is most of the time because of secretions, and you can do a parasagittal long axis scan to see how much is the tracheal diameter, and whether it is reduced because of some secretion or clot or some artifact or what is happening. So you can definitely guide with that, and also you can check where the ventilation is happening if lung is collapsed. And so I'm sure I'm not here to give a message that ultrasound is everything. It is the person, the clinical judgment behind the ultrasound which is more important. If you're logical, if you're thoughtful, you can always use ultrasound to your advantage. And a thoughtful clinician is the last word. Ultrasound is a gadget, and you can always use it so that the safety of the patient is enhanced and we have excellence in anesthesia care.
Yeah. Thank you, Dr. I think we can conclude our session. Is there any more question? One more question we have in the chat box. Can energy of airway in Ludwig's angina and IND occupancy beneficial? Please throw light.
Ludwig's angina. Yeah. So yes, we have done, but what the primary function of ultrasound scanning is to help our surgeon. So I would use ultrasound to see, because we were doing ultrasound guided airway blocks as well. So some area, some knowledge about pharyngeal anatomy, if we already have, then we can correlate that. We can pick up neck abscesses and how much it is causing indentation on the airway and how much impact it has got on airway, so that we can correlate. And already we are geared up when it is quinsy and this type of cases. I'm sure I have helped surgeon to guide the path, as I recollect one case, as what should be the puncture point. Even sometimes we have drained externally or through neck. So we could help them with the highest point where we can have maximum drainage of abscess and all that. So yes, I mean, the more you see cases, more you are thoughtful and you try and apply the principles of focus. I mean, it is useful. So you need to find one question and then you try to apply all these interrogations, the focus principles to find the answer to that question. So what should be the puncture point for abscess drainage outside on the neck? If this is my question, I can do a focused interrogation in that neck area to find. And I'm sure some of the areas are new to us, because nowadays in pediatric patients we have even picked up pyloric stenosis and neonatal volvulus, gastric volvulus with ultrasound, but we are not so trained as that of radiologists. So it is always good idea to involve a radiologist. Sometimes they do ask us to comment on torsion testes and vascular pulsation. I said it is a domain of radiologists and we are not here to replace them and other medical legal aspect, but we do utilize this opportunity to see the vascularity. So you have so many areas are opening up, and as you clinically correlate, you can help your surgeon and finish those cases with a lot of safety. Thank you.
Thank you, Amit sir. I hope we can conclude our session. Thank you. Thank you very much. This was a very wonderful talk by Dr. Amit Dixit. We are very thankful to sir for accepting our invitation and making today's event a special Valentine treat to all of us to focus on focus.
Thank you so much.
Success is no accident. It is the hard work, perseverance, learning, studying, sacrifice, and most of all, love of what you are doing. I hope today's session will definitely encourage each one of us towards need of excellence in our practice. We are very grateful to our esteemed chairperson, Dr. Bhale sir and Dr. Sujit Khade sir, being hectic day of working still with us for wonderful interaction. Also, I thank Maharashtra State Chapter ISA for providing us this digital platform. Our IT team from Jenica, Mr. Akhilesh and Ms. Varsha for providing us the Zoom link and the flyers and the IT technical help. Thank you all, Long Link ISA. Just two announcements. We have one hemodynamic workshop in the next month. That would be an hands-on workshop. And in the month of April, we are organizing ISA national sponsored CME. So looking forward for physical meet in the month of April. So we expect large amount of registrations from everyone. Thank you. Thank you, Dr. Amit.
Thank you, Amit.
I enjoyed a lot.
Yeah, thank you.
Thank you.
Thank you, Amit. Excellent presentation.
Thank you, sir.
Thank you, Amit.
Thank you,
Thank you,
sir.
sir. Thank you very much. Thank you, madam. Thank you, sir.
Bye.